Hello and greetings. Today, I'm going to be speaking on an update on H. pylori eradication treatment. My name, Benjamin Gold, and I'm here in Atlanta, Georgia at GI Care for Kids, Children's Center for Digestive Health Care. I also run the eradication program at Children's Healthcare of Atlanta and used to be the director of the Helicobacter lab at CDC. Also happened to be the president of NASPGHAN. It is my indeed honor, privilege, and pleasure to be participating in the NASPGHAN Junior School. I can't be more appreciative of the collaboration we have between our two societies, and I look forward to this next few 40 minutes of presentation with you. The objectives of this talk are as follows. First, I'm going to talk about, in the context of the microbiome, its evolution and part of the human evolution, where H. pylori fits. And some of the speculation about H. pylori maybe not necessarily being all bad, and whether or not when in treating the organism, we need to think about leaving it alone, or if you find it, treat it. I'll talk about, because it's important to understand this, in the context of updating treatment, the epidemiology and transmission of H. pylori. This is key because I'm going to feature some very recently published, just in this past few months, new guidelines, and clearly where you live, what your ethnicity and race and the part of the world that you come from dictate how this bacteria plays a role in the pathogenesis of disease or not disease. So I'll talk about why H. pylori may not always have been bad and may have been part of our normal gastric biome at some point in time. And then I'll talk about the specific diseases in the gastric and duodenal areas caused by H. pylori and why it satisfies Koch's postulates. And then this question of whether H. pylori is related to asthma, allergies, and atopy, and that why I still feel in 2021, November, when you find this organism, you kill it, you get rid of it, and you treat it like an infectious disease. And I'll review the therapeutic approaches to H. pylori and antimicrobial resistance. So first, the human microbiome, or the gut microbiota. It's important to recognize that the microbiome has two main components: the microorganisms that are inside and their byproducts. That in itself is the microbiome. And there are 100 trillion bacteria that live in our GI tract, 10 times the number of human cells, 100 times as many genes as there are in the human genome. So in many ways, we are actually more bacteria than we are human. And this is a logarithmic scale that shows on the right, microbial genes, and on the left, human genes. We really are more microbe than we are human. And this colonization, many recent studies over the past year demonstrates that founder species of microbes actually occur within 16 to 20 weeks of gestation. We normally thought that the amniotic sac and where the embryo was growing was sterile, and in fact, it may not be. And there's some elegant studies that have started that are showing that foundation microbial species occur even during gestation and during pregnancy. And the partnership between microbes and humans has evolved over thousands of years. And when you talk about the microbiome with respect to any disease, and this is a paper published about 3 years ago, this shows you with the y-axis being publications per year, the x-axis being years, and you start from the left in 2006, you can see that whether it's infection, cancer, liver disease, allergy, brain disorders, or even cardiovascular disease, the relationship between the microbiome is becoming more and more clear, or in some cases, more cloudy. And the body's microbiome really can be thought of as different compartments, whether it's the mouth, the skin, or the gastrointestinal tract. And each compartment has its own unique microbial signature. And the microbes are not just bacteria, they're fungi, they're viruses, they're parasites and protozoa, and that the gut microbiota, together with the human host, work together to make this superorganism. And I think where the most exciting research is going on now is maybe if we understand the host genetics and we understand the microorganisms, we might be able to prevent long-term development of disease by manipulating the microbiota and microbiome early in life. And dysbiosis is a concept to take home from this talk, and that it's the perturbation of the normal microbiome that then disrupts the symbiotic relationships and results in diseases, IBD, gastritis, IBS, and even cancer. And when you look at the GI tract, there are different biomes, if you will, in each compartment. There's the distal ileum and the colon, where dysbiosis results in diseases like neck and IBD. In the esophagus, there's the esophagiome, and dysbiosis results in eosinophilic esophagitis, H. pylori in the stomach, and celiac disease. And if you look at this elegant paper published about 3 years ago by Dirk Haller and colleagues, each component of the gastrointestinal tract has its unique microbial signature. That's normal, and then the dysbiosis results into disease. Now, what about H. pylori, to bring it to the topic of this lecture? And this picture here up on the upper right is a picture of Barry Marshall on the left, and Robin Warren, his longtime mentor and a well-renowned gastrointestinal pathologist, on the right. And they're smiling because they're sharing their check for $1.3 million, and where they won the 2005 Nobel Prize for Medicine and Science. In a very unique story, which for sake of time, and it's a shame that I can't go through, but in essence, where Robin Warren, the pathologist, who'd been describing these microorganisms in people's stomachs with ulcers for years, really wasn't until Dr. Marshall was a fellow in his lab and actually was able to isolate the organisms. And then when challenged as in lectures, he actually drank a cocktail of these organisms and resulted in causing disease, that the premise of the organism causing peptic ulcer disease came about. So the question that I'll leave to you to think about in the beginning of this lecture is, did Marshall and Warren, as well as the Nobel Prize Committee, get it wrong? Meaning, are all H. pylori really bad? And if you find it, do you need to leave it alone in some people? Well, what is it when it comes to children? The first guidelines, the Canadians were first out of the gate, 1999. Phil Sherman, my mentor, and others, and actually had the pleasure of participating in this guideline, published the Canadian guidelines. Nicola Jones, who I'm going to talk about, and who's the leader right now of the H. pylori working group between NASPGHAN and SPGHAN, published the update in 2005. Brendan Drum published the first European guidelines in 2000, and we published the first NASPGHAN guidelines in November of 2000. Then we updated these guidelines, and it was the first ever transatlantic guidelines in 2011. And then these guidelines got updated again in 2017, and we're actually beginning the process of updating them yet again, so that every 5 years we'll have an updated guidelines for SPGHAN and NASPGHAN. But is that germane? And more importantly, being that this talk is being given to the LASPGHAN Junior School, is this apropos for those living in Central and South American countries? And I'm going to talk a little bit about the transmission and epidemiology of H. pylori, because this is key to answering that question. And if you can prevent the infection, then maybe bad outcomes like gastric cancer won't occur. So how is this organism transmitted? Well, it's transmitted from person to person. Moms or maternal transmission is the most single important route. Very next in line are siblings. So if there's a household where there's more than 2 to 3 children, there's a higher rate of transmission amongst persons. Where you were born are all major determinants of infection acquisition. We've been involved in this, and this is a study that we did with the CDC in Bolivia, where we were looking at the safe water vessels shown in the image in the caption on this article, where the safe water vessels, where everything that you did that involved water, from washing dishes to cooking to drinking, was all done in these safe water vessels with sodium hypochlorite used as a decontamination tool. And what we did was we had two villages. These were villages at sea level in the La Paz area. All members were screened by UBT, and then everybody treated. And then one village had the safe water vessels, and one village had no vessels. And then we looked at infection reoccurrence. And what was amazing, or maybe not surprising, is that in the village that did not have the vessels, a reoccurrence rate at 6 months was 90% in the screened and treated individuals. In the village where those safe water vessels were used, the reinfection rate was less than 40%. So pretty amazing in that the first study that really shows you can potentially prevent recurrence of the infection. In a study that looked at, this was actually using sera that was obtained, looking at impact of Western civilizations in indigenous populations, and in particular looking at sexually transmitted diseases, where these are from indigenous Amazon villages, 22 different ones. The overall prevalence of H. pylori was 92% in this highly sensitive and specific assay used for epidemiological studies, and 80% were H. pylori positive by age 3. What's important to recognize is that H. pylori seroprevalence did not correlate with the length of contact with the outside world, suggesting that H. pylori was actually indigenous to the Amazonian Indians, the native Amazonians, and not introduced by Western civilization. This paper, published now almost 20 years ago, was the first that highlighted the fact that this organism may be as old as humans and part of the gastric biome. When you look at the primary reservoir, it really is humans, and the environmental reservoir that continues to be come up time and again is water, but typically fecally contaminated water in areas where there's poor infrastructure and poor water hygiene. A number of zoonotic sources ranging from flies to sheep have all been looked at, but it's actually been shown that although cats can have their own Helicobacter H. helmani, which can infect people, their zoonotic transmission is relatively uncommon. Primary acquisition period is childhood, and I have a list of factors that lead to higher prevalence rates of the infection. And it's important for you to remember these, because when you think about that child that's in your office that you're going to be treating, or that you're thinking about testing and then treating if you find it, where they come from, and particularly the area that they come from, may be that which dictates whether or not you need to be aggressive about looking for the organism or not being so aggressive. When you look at the rate of peptic ulcer disease, and this is a paper published just a year and a half ago by Marie Bougard and the late Sammy Cadronel and Patrick Bottoms, who actually I'll be on a conference call with tomorrow about the update guidelines. 7,849 endoscopies in almost 6,000 children with a median age of 7.6 years. And what they showed, what the proportion of ulcers without H. pylori may be higher than previously suggested, but that this prevalence hasn't changed for almost 2 decades, indicating that H. pylori still is a major cause in this particular study of a large number of children over a 23-year period. H. pylori is still a major cause of peptic ulcer disease. So what are the diseases associated with H. pylori? And this is a seminal paper published in the New England Journal, which really highlights it best. You can see on the far left where the x-axis is childhood, and then the y-axis is level of acid production. There's normal gastric mucosa. H. pylori colonizes, you get acute infection, and then it persists, and there's chronic infection, and this goes to a variety of diseases. And even now, where the first organism and first paper that appeared out of about H. pylori was in 1982, in 2021, we still don't know exactly who gets infected, who's going to develop ulcers, who's going to develop asymptomatic infection, and who's going to go on to develop gastric adenocarcinoma. And I think this is one of the pivotal questions that more research is necessary in order to understand this sort of disease dilemma in terms of understanding who you need to be the most aggressive about. Childhood factors, particularly host and bacterial factors, are shown at the bottom part of this slide. So who is Cox? Dr. Koch, who is a microbiologist, and what are his postulates? And I think it's important to recognize this because this allows one to really understand why H. pylori is a pathogen. The microorganism, in this case H. pylori, must be found in abundance in all patients suffering from the disease. The microorganism must be isolated from the diseased organism. So that's what Dr. Marshall did with Robin Warren's help. And then the cultured microorganism should cause disease when introduced into a healthy organism. And that's Dr. Marshall's infamous or famous slurry of H. pylori cocktail that he drank. And then you need to be able to isolate that organism from the new host that's now infected and infect and first show that it's identical to the one that was used for the infection, and then being able to infect someone else and cause disease. And H. pylori clearly does this for peptic ulcer disease. And there's Robin Warren and Marshall on the lower right toasting champagne after their Nobel Prize and not drinking H. pylori. H. pylori clearly causes gastritis. And in fact, every person who's infected is going to have a low level of gastritis. Now you say, well, Dr. Gold, then why don't we just scope and treat everybody? And the problem is that we still don't know who that are infected that have gastritis are going to go on to develop cancer, ulcers, or just have gastritis that never really brings that person to the attention of a physician. And you don't scope asymptomatic people, but clearly gastritis is caused by H. pylori in infected persons, and there are a number of animal models that have been looked at. Ulcers, again, 5 to 15% of infected persons, duodenal ulcers in children, a higher prevalence rate than gastric ulcers. And in people who are on chronic non-steroidal anti-inflammatory agents, there clearly has been data that demonstrates that there's worse gastric and duodenal disease in infected persons. So if you have somebody who needs to be on chronic NSAIDs and they have been tried on or off a PPI and they still have abdominal symptoms, it may be worthwhile looking for H. pylori, and if you find it, get rid of it. Gastric adenocarcinoma, and there's even animal models of gastric carcinoma, satisfies Cox postulates, and malt lymphoma. And in fact, this rare mucosal associated lymphoid type lymphoma, even with metastases in extra gastrointestinal sites, if you treat the organism with eradication therapy, antimicrobial therapy, those metastases actually melt away. So there's an amazing immunology that we still don't understand with respect to the relationship between this organism and malt lymphoma. And we were the first to describe patients with H. pylori infection, high gastric cancer risk based on the population that they came from, and actual atrophy with intestinal metaplasia. To show you that this works, and this is a paper just published last August from the Matsu Islands. In this particular study, mass eradication of H. pylori was launched in early 2000s, 2004, and continued to 2018 in this high-risk Taiwanese population, 30 years or older. And what they showed was that in population-based eradication, significantly reduced new cases of gastric cancer, and they had no increase in likelihood of adverse consequences. So the first population-based study in over 7,600 people that demonstrated that when you screen and treat in this population high at risk for gastric cancer, high at risk for H. pylori, you actually can reduce incidence rates, incidence meaning new cases of gastric cancer. And in this paper published in the New England Journal just this past year, among persons with H. pylori infection who had a family history of gastric cancer and first-degree relatives, H. pylori eradication treatment reduced the risk of gastric cancer. So we kind of go back and forth, but in certain populations, and this is why getting a good history in your patient in your office is very clear, particularly the epidemiology, their race, their ethnicity, what country that they're from, because there are risk factors that put them in a category where looking aggressively is important and can reduce incidence rates of gastric cancer. Now, what about disease outside the GI tract? There's been a number of mechanisms for iron deficiency with or without anemia that have been described. They clearly have evidence for biologic plausibility. And H. pylori eradication studies have demonstrated evidence supporting cause and effect for H. pylori infection and iron deficiency, as well as anemia in certain populations. And in fact, if you have a patient with undiagnosed or mechanisms for the iron deficiency and iron deficiency anemia not elucidated, then it would be important to look for H. pylori. We've got a paper that is been submitted for publication with my collaborators in Japan, actually showing in elite adolescent athletes that eradication of H. pylori clearly resolves iron deficiency and iron deficiency anemia. ITP, idiopathic thrombocytopenic purpura, is an acquired bleeding disorder where autoantibodies bind to platelets and they destroy them in the reticuloendothelial system. And H. pylori infection appears to be higher in its prevalence rates in those patients with chronic ITP compared to those that don't have ITP. And eradication of H. pylori actually results in normalization of platelet populations in up to 60% of patients. The mechanism of this resolution of ITP still remains unclear. So there's currently insufficient evidence that H. pylori infection is causally related to otitis, periodontal disease, SIDS, coronary artery disease, and atherosclerosis, but a growing body of evidence that H. pylori is a causal factor leading to short stature, poor growth velocity, and continued controversial association with things like IBD, asthma, and allergy. So the question to ask yourself, are there good, okay, or really bad H. pylori? And once you find it, is the only good H. pylori a dead one? Well, so ask yourself, what would you do? If a patient has recurrent abdominal pain, it's not an indication to test for H. pylori infection, particularly if you have the idea that it's functional abdominal pain. And H. pylori testing is not required in patients with newly diagnosed reflux disease in whom PPI therapy is to be initiated. However, when long-term treatment with a PPI is planned, you may want to consider H. pylori testing, particularly if they come from an endemic population. And if the H. pylori is found, then eradication should be achieved. Now, what about this whole question of H. pylori and whether or not it was originally part of the human microbiome? And is there an association with allergy, atopy, and asthma? So if you look at this particular set of figures published from a landmark paper almost 20 years ago, on the left, incidence of infectious disease dropping. On the right, incidence of immune disorders, autoimmune and atopy, increasing. And if you look at a paper published 3 years ago about worldwide prevalence of H. pylori, in certain populations, prevalence rates have dropped dramatically, and in others, it remains over 70%. And those are highlighted by the dark brown in many parts of Latin America, Africa, and Asia. So as the prevalence of H. pylori has decreased, the incidence, that's new cases of asthma, autoimmunity, has increased. So there's an inverse relationship between H. pylori and diagnosis of allergic asthma. So the question you might ask is the increase of asthma and atopy and correlate decrease just an association, or is H. pylori actually protective? Or maybe, and I think this is what the data is bearing out, is H. pylori really a marker of the hygiene hypothesis? And as we've improved overall infrastructure in many countries and people are becoming more hygienic and living in less crowded situations, better water hygiene, et cetera, then we've gotten rid of the organism and the microbiome has changed. And this is a particular schematic published just a year and a half ago, which highlights the relationship between exposures up on the top and disease down at the bottom, and postulated mechanisms of the autoimmunity and or allergy. What about H. pylori and back in time association with disease? So in pre-Columbian Mexican studies of mummies that were evaluated, they demonstrated H. pylori in pre-Columbian mummies dating back to 1350 Antichrist, and 2 of the mummies had gastric ulcers. In a study done in northern Canada, British Columbia, they demonstrated that H. pylori DNA was isolated from stomach tissue in a number of First Nation populations, again, realizing that these had no impact or exposure to Western populations, and these organisms and disease were found. And in this particular paper published from the group in New Orleans, Andean mummies revealed H. pylori, particularly in mummies that had gastritis and in ulcers. So there's clearly data that shows that this organism has been around for well over 2,000, if not more, years, and associated with disease, gastritis, gastric ulcers, and duodenal ulcers in infected individuals. So the hypothesis is that when modern humans left Africa about 60,000 years ago, they were already infected with H. pylori. And that as we've evolved, these bacteria have subsequently diversified in their human hosts, and H. pylori is adapted, colonizing children and persisting through life. And many strains possess factors that subtly modulate the host environment, resulting in some people the risk of ulceration, some people the risk of gastric adenocarcinoma, and possibly other diseases. So now, how do we diagnose H. pylori? And the first thing to remember is that the diagnosis is going to be targeted at what is the cause of the gastrointestinal symptoms, not just the presence of H. pylori. And that's been very clear throughout any of the guidelines published for H. pylori. And if the endoscopy is performed and there's persistent abdominal symptoms, then consider testing. And when H. pylori infection is detected, even in the absence of peptic ulcer disease, H. pylori treatment should be considered. And this particular relationship, if a history of gastric cancer exists in primary relatives, so aunts, uncles, and grandparents of that particular child, then testing is suggested. And this has been evolved into where they're from and what the risk of gastric cancer might be. For the diagnosis of H. pylori during upper endoscopy, it's recommended that you obtain gastric biopsies from the antrum, the incisura, and the corpus, and that the pathologist uses the updated Sydney classification. It's recommended not to perform biopsy-based tests and to urea non-invasive tests, either the UBT or stool test, for at least 2 weeks after stopping PPI therapy and 4 weeks after stopping antibiotics for the diagnosis. Culture and PCR primary means for antimicrobial susceptibility profiles. And I'm going to give you a little bit of an update in terms of what we now have established in our lab and the ability to use us as a reference lab. UBT is the most reliable non-endoscopic test to document eradication success. Monoclonal fecal antigen test provides another non-endoscopic means, and testing for eradication appears to be the most accurate if performed at least 4, preferably 6 to 8 weeks after you complete antimicrobial therapy. The bottom line is, and I think this is important because this is not how we addressed H. pylori in the early days, treat H. pylori like an infectious disease. If you find it, you treat it, and then you make sure that it's gone by some type of test for active infection 6 weeks after you complete your antimicrobial therapy. Now, to conclude in the next few slides, how do we treat H. pylori? So first line eradication regimens twice daily for probably 14 days, PPI based with 2 antibiotics, amoxicillin or an imidazole, amoxicillin or clary, triple therapy with bismuth salts, And there's some data that is starting to suggest that even quad therapy for a month might be the best first-line regimen. It's recommended that the duration of triple therapy is 14 days. It's very clear in many studies from around the world that longer treatment is better, and cost compliance and adverse effects should be considered. And then a reliable non-invasive test for eradication is recommended at least 6 weeks following completion of therapy. This is a particular novel study done by Dr. Nicola Jones and our colleagues in Toronto. And they've actually found that this bacteria is able to get into lysosomal vacuoles within the stomach. That's what's shown here in this particular slide. And that they're looking at novel therapies in terms of how to disrupt this mechanism that the bacteria uses to escape gastric acid and other digestive enzymes in the stomach. Korean guidelines were just published in March, evidence-based guidelines for the treatment of H. pylori infection, and again, very different because of the rates of gastric cancer in Korea. The AGA published their clinical practice update on refractory H. pylori infection just a couple of months ago. Sahila Shah was the lead author in this particular paper, and there's a lovely discussion on reasons for which refractory infection occurs. And you can see that in this particular slide here, taken from that paper, ranging from host genetics to strain diversity to system barriers such as non-adherence to treatment and other things. The updated Japanese guidelines for the management of H. pylori infection in childhood was also just published in this past year, and I had the honor and privilege of being one of the co-authors in this particular guideline. And again, different somewhat in terms of the epidemiology, the infection and disease outcomes in populations. Now, what about antimicrobial resistance, and why is it an issue we need to be concerned of? The primary reason for failure is non-adherence. You just don't take the medications. And reinfection of other family members could potentially be a source for the infection not being able to be cleared. And resistance rates have been rising fairly dramatically, with metronidazole being the highest resistance rates worldwide. And I'll show you some of those numbers, but clary or clarithromycin resistance and macrolides having the greatest impact on therapeutic failures. The guidelines published in 2017, and we're in the process of updating these, recommend that if you can get antimicrobial susceptibility, and if you know the epidemiology of clary resistance in your region, then that should be used in terms of determining whether or not you use clary in the first line treatment. Clary resistance in 2019, and this is going to be updated, is shown in this slide here, and it ranges from 5% to 48% in different countries. In Latin America, it's 17 to 42%. Metronidazole resistance ranges anywhere from 7% to 82%, and actually that has been found in countries within Latin America where metronidazole resistance is 50 to 82%. Felt likely to be due to the prevalence rates of protozoa. In Europe, this is a 2017, so 3.5-year-old, 4-year-old paper, found clary resistance, and this is just children, almost 25%, metronidazole resistance 43%, and levofloxacin resistance 16%. And a paper published in Microbial Health and Disease a year and a half ago talks about the potential need for quadruple therapy for at least a month in order to best achieve eradication rates greater than 90%. And we have just opened our diagnostics laboratory at Children's Healthcare of Atlanta, as shown in this particular slide here, where we actually can do resistance testing even in paraffin-embedded blocks, at least for clary. And if there's a treatment failure after you use a regimen that's non-clary containing, should you have a clarithromycin-resistant strain, then we can provide resistance testing for all 4 antibiotics. So to summarize, there are no randomized controlled trials evaluating efficacy of different regimens and newer antimicrobial agents in children. Novel therapies that show promise are probiotics and the fluoxetins. Vaccines are still being looked at, although again, it's still not clear that there's going to be a role. And antimicrobial resistance, as I've mentioned, is still a main factor affecting outcome. Controversial remaining questions: the need for regularly available antimicrobial resistance testing to guide therapy is key. And collaborations like with NASPGHAN and LASPGHAN to potentially set up registries to look at antimicrobial resistance in different Latin American countries may be key in terms of better treating this as an infectious disease. We still need to determine who gets infected, develops what disease outcome, and is there a point where there's gastritis and atrophic gastritis where the disease progression to cancer becomes irreversible. So the question that I postulated in the beginning of the talk, and I'm going to conclude here, is once found in a child is the only good H. pylori a dead one? And my answer is today, November 2021, yes. And with that, I'd like to conclude. I want to thank you all for your kind attention. And I do hope that this stimulated some thought and discussion. And thank you so much for the honor and privilege of presenting to you.